As a sports science team, focus now is more on injury prevention, strategies in elite sports person. Okay, it is pertinent. We understand the repetitive movement patterns which are happening in our cricket, not only in cricket, in all the other sports, and the adaptive shortening as a result of this repetitive movement, how it can impact in the structures and structures around the joint. Okay. So, this repetitive movement and shortening varies from athletes participating in different sport depending on the demands of the sport actually. Over the period, if you can see, we have been doing this MSK screening, and recently we started implementing the injury prevention protocols, and in these things we have been still been monitoring the dorsiflexion range, but for what reason we are doing, we actually not very sure about it yet, I guess, because even a smallest difference in the ankle dorsiflexion range can cause mechanical change, that is bowling mechanics of fast bowlers. This we need to understand, and correcting this dorsiflexion range can impact the total overall mechanics of the fast bowlers. So, in this presentation, we would like to hypothesize the lead leg ankle dorsiflexion range of motion restriction leads to the altered transverse plane mechanics of fast bowlers. This is the hypothesis. Myself and Suresh, who was supposed to be here for the presentation, is not here. So, it is a very interesting topic. It gives us a couple of questions already. What are those? Do we have sufficient data to support this hypothesis? So, over this presentation, this is what I am going to discuss, and I am going to explain how these things happen and why only the lead leg data we are looking at. And the third one is, does what really causes this dorsiflexion limitation in the fast bowlers, particularly on the lead leg. And the last one we would like to go through will be the how it can affect the transverse plane mechanics of a fast bowler. We all know the dorsiflexion and plantar flexion is entirely in a different plane, but how we can affect the rotational component, that is in the transverse plane motion, how it can affect, these are the things which the questions which we need to answer, and we need to understand how a dorsiflexion range of motion can lead to all these questions. So, going in detail, I just want to start off with the inferior tib fib joint, that is the talocrural joint. Before going into that, I just want to explain a little bit on to the inferior tib fib joint, which is actually on the medial side by the tibia and the lateral side by fibula. The main reason for this joint it's the shock absorption. So, there is a little bit of joint play which is possible in this joint. So, we are not totally thinking about that particular joint. So, we need to go a little bit beyond, like how the talus movement and subtalar movements are going to cause this the dorsiflexion range alteration and biomechanics in the fast bowlers. So, looking on to this joint, the fibula has a pronounced tubercle which prevents it from sliding around, and but it just gives the joint stability. So, it gives the ability to move a little bit, but not entirely sliding part, it does not happen. So, when there is a load on the tibia, when there is a load is happening on the tibia, what happens is it rotates medially and the fibula rotates laterally. So, this gives the talus which has got a larger body, that is this gives more space for the talus to wider in front and rather than in back. So, more the talus comes under the tibia, the more space it needs, and the fibula glides by giving a bit of space for this movement to happen. So, going into the talocrural joint, it is basically a simple joint, a hinge joint, where we can see only dorsiflexion and plantar flexion motion happening in this joint. So, this talocrural joint is basically, we call this as a mortise, Carpenter's mortise, which we all know already. What exactly it says? It's a small box, like a talus is a small box, fits into a box formed by the calcaneum, concave tibia and fibula, where the talus is concave and tibia and fibula are convex. The primary function of this joint, as I said before, is just a plantar flexion and a dorsiflexion movement. So, the next one I want to talk about is about the talus. So, when the weight bearing is happening, talus is sort of sitting in middle. So, if you can see, talus sits in middle between the top one, the tibia and the calcaneum. So, it acts actually a torque converter. So, any load is happening on the talus, goes into the tibia, goes into the talus, and the force is being dissipated. Medial malleolar surface in the talus, if you can see, there are two surfaces, the medial facet and the lateral facet, and the medial malleolar facet, which connects with the medial malleoli, is bit shorter or smaller compared to the lateral facet, which accommodates the fibula. This is a very prominent anatomical marking, because it supports the fibular glide movements during the dorsiflexion or the subtalar movement actions. So, thinking on the load on the talocrural joint and the medial rotation, the integrity of the medial ligaments is of a paramount importance. So, the integrity of the medial ligaments as well as the lateral ligaments, what it does is, it makes sure the fibula stays in place, and when loaded or whatever movements we do, it stabilizes and it makes a very little movement through the lateral structures. So, as I said, to understand the normal, first we need to know the normal kinematics, so that I can explain in better when it happens any pathomechanics or any dorsiflexion limitations, what all structures are getting involved and how it alters the mechanism altogether. So, in a normal mechanics, in an open chain scenario, the talus rolls anteriorly and tilts posteriorly, which causes this posterior structures like the Achilles tendon or the posterior capsule or calcaneofibular ligament gets stretched. And at the same time, when the dorsiflexion happens, if you can see, there is the anterior structure slackening happening, where the anterior talofibular ligaments or the anterior capsule getting slackened. So, this is during an open chain mechanics when the foot is off the ground. So, the same thing when the in plantar flexion, it is exactly opposite, where there is an anterior roll, anterior tilt of the talus and posterior roll of talus, and also causing the anterior structures to be on stretch or in tension. So, the posterior structures or the posterior capsule and the calcaneofibular ligaments are relaxed at this point of In a closed kinematic chain, if you can see, when the foot is fixed in the ground and the concavity formed by the mortise rolls and slides the movement in the same direction over the convex surface of the talus. The dorsiflexed ankle is stabilized as the wider part of the trochlea or talus wedged into the mortise. So, it is the roll, if you can see, it is on the same direction compared to the one which is happening in the open chain, where it happens in the opposite direction. So then we need to understand little bit about the subtalar joint. The subtalar joint articulations is the articulation between the facets of the inferior surface of talus matching the facets on the superior surface of the calcaneum. The talus anterior and medial facets are convex. I think the talus, the anterior and medial facets are convex and posterior facet is concave, whereas in calcaneum it is the right opposite. So, if you can see the calcaneus, the anterior and medial facets are concave and posterior facet is convex. Due to this anatomical variation, the important point we need to understand is this: the body, that is the movements are in opposite direction. What I mean to say is, when the head of talus is moving inwards, you can see due to this anatomical variation, there will be the movement on the opposite direction. Yeah. So, also this subtalar joint, what is the main movement is that it allows oblique arc of motion that results in combined motions of inversion and adduction or eversion and abduction. So, the main movements we can see will be inversion and abduction and eversion and inversion and adduction and eversion and abduction. These two components are from these two components of the supination and pronation movements of the foot. So, next we need to understand about the subtalar joint, the steering wheel mechanism. So, how this is possible? Because we need to understand the lateral collateral ligaments limits the inversion and adduction mechanism, like the anterior talofibular and posterior talofibular limits the inversion or adduction movement of the talus, whereas the medial ligaments like medial deltoid, which includes posterior talotibial ligament, limits the eversion and abduction of the subtalar movement. So, here in this slide, if you can understand the collateral ligaments of the ankle forming a ring, it actually forms a ring resisting the horizontal rotation of talus by tension in the opposing pairs. So, what I exactly mean is it forms as a ring and it creates the resistance in the as an opposing pair. So, if you can see the anterior talofibular ligament and the deep deltoid ligament resist the internal rotation moments, that the horizontal rotation of the talus, it does give a resistance on it, whereas the posterior talofibular ligament and the superficial deltoid ligament resist the external rotation of the talus. So, this concept is very important in understanding how these subtalar movements can affect the transverse plane mechanics of the fast bowler. So, even though the movements restricted is dorsiflexion during the bowling mechanics in the leading leg, any restrictions there, it can cause the reverse mechanics applicable in the subtalar joint movements due to these muscular patterning or adaptation of the soft tissues can cause the tightness in these structures and resulting in the movement restrictions. So, I want to discuss little bit on the motions of foot. The leg and talus move as a single unit over the fixed calcaneum. The subtalar joint allows the relatively small horizontal and frontal plane rotations of the leg and talus that naturally occurs when lower extremity is in contact with the ground. So, when in a closed chain supination position, if you can see there is a calcaneal eversion, it has been compensated or been adjusted with the talar posterior tilt and abduction, and tibial rotation, external rotations happen. So, the subtalar joint allows the leg to remain vertical even while standing, walking or running or on the uneven surfaces, acting as a steering wheel. So, basically even the calcaneal eversion happens or inversion happens. So, it maintains remains vertical even while in standing, walking or in the running process. All right. So, what exactly happens during the heel strike? So, during the heel strike we can see these movements occur, like a plantar flexion with combined with supination, calcaneal eversion, calcaneum gets everted, talus abduction and tibial external rotation. So, these are the movements we see while during the heel strike, that is during the front foot heel strike movement. When there is a dorsiflexion range of motion limitation, maybe due to any of the soft tissue adapting or any structural adaptation happening here, what exactly happens? So, we can see there is results in the inversion and adduction of talus, causing the body of talus to abduct, and external rotation of tibia is evident during this process and leading to the posterior glide of tibia. So, whenever there is this restriction in the movement, this cause movement the structural adaptation happening and the leading to the posterior glide of fibula. The structural changes or adaptations which happens include slackening of the anterior talofibular ligament and the posterior deltoid ligament. If you can see what other structures can go for tightness will be the posterior talofibular ligament and superficial deltoid ligament can be tight, and it can cause the limitations in dorsiflexion. So, the other restrictions we can expect will be the posterior glide or tilt of talus, which will be restricted due to this tightened structures, and also causes anterior glide of tibia over the talus. I mean to say there will be a restriction of anterior glide over the talus. This is explained in this slide. So, the inversion and adduction of the head of talus is the whenever there is a dorsiflexion limitation, we can expect there is an inversion adduction happening at the head of talus, abduction and eversion on the body of talus, and external rotation of tibia is evident, and also there will be a posterior glide of fibula. So, the structures which can go for the adaptive shortening or lengthening will be, there will be a loosening of slackening of ATFL or and the posterior deltoid ligaments, and the structures like the posterior talofibular ligament and calcaneofibular ligament goes for tightness along with the anterior deltoid ligament. So, this results in the restriction, as I mentioned, on the posterior glide of talus and restriction in the anterior glide of tibia. So, that way these are the restrictions we can expect. So, what we did is in the recent assessments, what we gone through, we have assessed 28 elite fast bowlers in NCA who are part of the high performance camp. We have come across these data where there is there is a difference in the front foot dorsiflexion range of motion in the fast bowlers. Out of these 28 fast bowlers, on an average there was a difference, the average the front foot dorsiflexion range of motion was 14.26 centimeters, whereas the trail leg, if we could see, there is a 15.5 centimeters on an average. Even though it is a very short study, we need to explore more on more, and there will be researches and more more assessment and protocols has to be followed. Even though they are these players are actually being followed in the state associations, but even after such follow up for 6 months, we can still see there is a difference happening, and why it's again happening, why it is not getting improved. It's something we need to think about. There should be a process where these muscular adaptations can be corrected, and thereby it can lead to injury free or any mechanical change aspects can be corrected. So, what the recent things we are doing at this NCA is, once we identify there is a dorsiflexion range of motion deficit is there, we do the normal, I think we all do the normal glides, anterior posterior glides, soft tissue releases in the calf region, but still we see if you reassess, we don't see much of difference in the dorsiflexion range of motion. What we started doing is, we go on targeted releases, where we are started releasing the structures we identified as the tightening structures which limit the dorsiflexion range of motion, like the posterior tibiofibular ligament, calcaneofibular ligament, and medial deltoid ligament. Also a part of the interosseous ligament between tibia and fibula. So, when we target and release, it just takes couple of minutes to do, and we could easily see, or we could see there is a difference achieved within couple of minutes time. So, whenever the player is being assessed during injury prevention screening, which we already, all the domestic physios will be aware of the process, we see them having a dorsiflexion range restriction, and we have literally have few minutes time to get them ready for the sport. We just go specific releases to this ligaments and structures around the ankle joint, so that the dorsiflexion range of motion is achieved, and the player, the other parts obviously, you know, the internal rotation, the hip internal rotation or thoracic rotation limitations will all can be done with the similar process we have been following before. So, do we, the questions I put it across in the first, do we have sufficient data on these? I would say we are still working on it. We just need to work as a unit, the domestic team, because not all the high performance data is not sufficient to creating this hypothesis success, or preventing the injury, doing the injury prevention protocol as success. So, we might need your help. We will definitely be in touch with the domestic teams to get more data, to create research or further thesis or further documents supporting our hypothesis. So, that is what I would say, we need more data and research on this. Why only lead legs? Yes, we all know now it is because of the repetitive loads on bowling, which happens on the lead leg, more ground reaction forces. So, this dorsiflexion range of motion limitation occurs mostly on the lead legs. What causes dorsiflexion limitation? Tissue adaptations and muscle patterning. Again, this is something we have been thinking about. Nitin Patel sir would have been discussed more in details, and this could have been followed his presentation, which would have made more sense, because he would have given the total patterning, you know, right from the ankle to the hand, how the muscle patterning happens. And the last one is the transverse plane mechanics, how a transverse plane, the rotational component, it is because of the subtalar joint movement mechanics, which alters the transverse plane movements. Even though the dorsiflexion happens in a different plane, the subtalar movement where there is a restriction or where there is any anomalies, it can lead to a transverse plane motion. Okay.